when you ask to have a minute of this group's time, you get the benefit of trying to have everybody quiet down, but you guys were super good at it, so I'm not hand it off. My name is Sadie Valentine, and I'm the program coordinator for the UConn Recovery Community. We are part of Student Health and Wellness, and we're happy to have Susanna Norado our Executive Director of Student Health and Wellness, and Karen McComb, who's our new Director of Health Promotion, here today because addiction is a big part of what we've been working on, and definitely focusing on recovery. One of the reasons I asked to be a part of this for just a minute is to let everybody know that we do have the UConn Recovery Community for our students. We have a beautiful building, 1,700 and something year old colonial right on Storrs Road that's dedicated to those students. And we have a variety of recovery meetings. So we have all recovery meetings. We're starting a SMART recovery meeting on Monday, and at the end of the month we'll have yoga and recovery sessions for students. But we also are looking to expand the reach of our programs by training folks to be allies and learning how they can best support students in recovery. So there's a sign-out sheet at a table out there on your way out. If you're interested in hearing when those sessions will be, we'll contact you via email. Because sometimes it's a challenge to know what the right way is to support a student who is either in recovery or is showing signs that a conversation about maybe pursuing recovery would be the right thing for them. And these postcards have all our information, so if you want to keep this in your desk in the event that something triggers the desire to start a conversation, and anytime you can reach out to me. So thank you for that, and I'll turn it over to introduction, Misty.
Yeah, thank you, Sandy. I want to thank Student Health and Wellness for being a partner with us today, and actually a partner on our whole lecture series for this year. We have many other co-sponsors as well, and we thank their support tremendously. So I'm Amy Warren, I'm the director of InCHIP, and I'm thrilled to see a full room for our first lecture of the year. This is such an important topic, and we're very lucky to have Dr. Winstanley here to present on her research, and Angela Starkweather is going to introduce her in a minute. Just wanted to make one quick plug that we are doing another Ideas Lab this semester. Ideas Labs are an interactive workshop designed to generate novel interdisciplinary research solutions to wicked problems. And our wicked problem this semester is how to prevent opioid-related deaths, which is a tremendous problem in the nation, but also in Connecticut. The rates are incredibly high here. I think we're 11th in the country in terms of opioid-related deaths. So this is an event geared towards faculty researchers, but across all disciplines. So we're looking for behavioral and social scientists, engineers, computer sciences, humanities, arts, business, and the like. So there's information on our website about that, but you can also come up to me at the end of the lecture today to learn more about it. So thank you for that. I'll turn to Angela.
All right, good afternoon. I'm Angela Starkweather, professor at the School of Nursing. I had the great pleasure of taking Dr. Winstanley out to dinner last night. She is just a wonderful researcher, and we're in for a pleasure of having her present today. So Dr. Winstanley is an associate professor at West Virginia University, Department of Behavioral Medicine and Psychiatry. She received her doctoral degree from the Johns Hopkins Bloomberg School of Public Health, and she has over 20 years of experience as a behavioral health service researcher. Her current research is focused on reducing the morbidity and mortality associated with the opioid epidemic, as well as the use of technology to improve access and quality of behavioral health services. Erin is a Connecticut native, and she grew up in New Haven. Her career as an addiction scientist started over 20 years ago when she worked as a research project manager with Dr. Tom Baver at the University of Connecticut Health Center, Department of Community Medicine. So maybe after her talk, she can fill us in on some of what she attributes to her passion for research today. So welcome.
Thank you so much. Thank you so much for the invitation to speak here, and for Amy and Michael, for Angela and Michael going out to dinner with me last night and really telling me about what's going on here, and Amy for the invitation, and Melanie and Josh and everyone who's helped put this together. It's not easy to travel from West Virginia anywhere. So has anyone been to West Virginia? Who's been to West Virginia? Is anybody from West Virginia? You're from where? Okay, so where have you guys been in West Virginia? Through. Did you stop anywhere? It was middle of the night.
The middle of the night, okay. Huntington, for how long? 24 hours?
No, 5 days.
5 days, okay, that's, okay. Anybody else?
I went to a wedding.
To a wedding. Where were you in West Virginia?
I'm trying to remember, it was so long ago.
Okay, anybody else? Charleston, okay.
I used to go to Morgantown.
Yes, that's where I live, so you know my town.
Charleston.
Charleston. So you can imagine what it's like. I was mostly an urban person, and I moved 3 years ago to Morgantown, West Virginia. So I tell people, I was doing work at the University of Cincinnati, which Ohio likes to compete with West Virginia as having the highest overdose death rate. And so I somehow, it wasn't bad enough in Ohio, so I decided to go into the belly of the beast, which is pretty much what I've done. So I like to share my life with you as also my research, so I like to take pictures. I recently took this picture of beautiful West Virginia. This is Babcock State Park, and so it's really an inspiration. Every morning I do get to see our Misty Mountains. I don't think I appreciate our country roads as much, or at least my car doesn't. So I don't have any disclosures. And this is a picture of the New River Gorge Bridge, which is one of the largest suspension bridges in the country. And right now, if you were to go, we have top-notch whitewater rafting going on right underneath this bridge, so it's really spectacular. It's also a little scary. Has anybody done whitewater rafting in West Virginia? Okay, you should do it if you want to live on the edge. So my presentation goals today are to summarize the latest epidemiological research on the overdose epidemic. I'm going to discuss strategies to prevent and reduce the non-medical use of prescription opiates. And I'm going to review evidence-based services to reduce the morbidity and mortality associated with the epidemic. And then I really want to talk about some of the barriers to expanding overdose prevention and addiction treatment in particular. So before I get started, it seemed to me that this is an interdisciplinary group, so I wanted to sort of just coalesce around some of the terminology I'll be using. And so while we often use the term opioids and opiate interchangeably, the broader term that most people are really using now is opioids, and that is inclusive of heroin and prescription opiates in particular. And so we have to remember, where does this whole problem stem from, right? So that morphine can be found in the Asian poppy plant. And this is a picture from, this is a statue from the 13th century. And it is the goddess of joy. And she is the bringer of both sleep and death. So really sort of foreshadowing what's going on with the epidemic. But it really starts off, right, as this very innocent poppy plant. And I want to talk about another term that's being used, you may or may not be familiar if you work in the field of addiction, is we're really referring to illicitly manufactured fentanyl. IMF is what it's known by short. So this is not medically diverted fentanyl. This is fentanyl that's coming in from other countries, primarily from Mexico and China, we think. And it's either adulterating or being combined with the heroin supply, or in some cases, fully supplanting heroin in some cases. So, and this is only one of the many opiate synthetics that's available. So we have some seats in the front if you'd like to come up. There's still some seats available. I would hate for anybody to have to stand. What's really complicated the epidemic right now is that very small quantities of fentanyl, in the case of carfentanil, can be highly toxic and fatal. So when I was in Cincinnati, Cincinnati was one of the first places to actually confirm carfentanil-related deaths. Carfentanil is a pain reliever for elephants. So one can only imagine how traumatic this is, or small quantities can be highly toxic. So this is me. I survived whitewater rafting. But what did I learn about whitewater rafting, and why am I showing you this picture? Is because it really relates to what we have to do in response to the opiate epidemic, right? So, it's one thing to raft. It's a whole other thing to put your life in the hands of everyone else who's in the raft with you, right? So I was scared. My family was okay, but we went around and did this again. And it really shows, which I think is what we need to do with the opiate epidemic, is to be able to work together on this, because you're not really going to get through this tough rapids if we don't do that. So the prescription opiates have increased for well over a decade. They started to decline in about 2011, and the number of pills started to decrease in 2012, but it's really parallel increase in both prescription opiates and the number of people who have died of overdose deaths. And it's problematic. There's two sides of the equation here, right? So it's the access to these drugs, prescription opiates, which are really needed for pain, which is very legitimate, but it can also lead to non-medical use. And then, of course, for some smaller subset, it can lead to the addiction or the development of an opiate use disorder. So this map is a map of the United States, and the darker shades that are almost black actually represent counties with higher rates of prescription opiate dispensing. So this is, I'm actually up in this part of the state of West Virginia, but you can see this really rural Appalachian area of eastern Kentucky, southeast Ohio, and southern West Virginia that really has still high amounts of prescription opiate dispensing. But one of the main pictures here is just to give you this emphasis that it's very hard to talk nationally what's going on when we know we have really big differences, geographic variations in dispensing patterns, overdose death patterns, et cetera. And then also keeping in mind, it's so easy right now to stay focused on this is just a heroin epidemic or just focusing on people who, the people who are at risk are simply people who are using illicit opiates, when in fact it's a combination, right? So it's many people, over 10 million people are suspected in the United States of misusing prescription opiates. And I'm not saying that they all warrant addiction treatment, but they're at risk. And we have very few interventions in that space. And it's really such a very small percent of those patients that actually are misusing both, it's less than 5%, are misusing prescription opiates and using heroin. So in the two sides of the equation here is remembering that we have people that are still at risk of potentially accidentally overdosing on their medication, and they have an unintentional overdose as part of their either recreational use of opiates, any kind of opiates. Again, this is another state, this is another map where the darker shades of red represent states with higher overdose death patterns. As you likely know, West Virginia, where I am, it's the belly of the beast because we have the highest overdose death rate in the entire country. It's been that way for quite a long time. So it was really in 2007, the CDC recognized overdose deaths as an epidemic. So we're a decade into this being an epidemic. But what's really going on, right, is that deaths have been increasing for 20 years. It's really 20 years that these deaths have actually been increasing. It's just in epidemic proportions recognized in the past decade. So we're 20 years into this, really. And trying to understand what that looks like in some of our hardest hit small communities is just a really challenging situation. It's really hard to imagine today that about there might be 192 drug-related deaths in the United States just today. So this is a really challenging problem, especially this many years into it. If you're not familiar, the CDC has come to describe this, and I think it's important to sort of realize if you're not familiar, is that we're talking about now 3 waves of an epidemic. So starting in 1999, remember I was talking about 20 years ago now, right? We started to see an increase in prescription opioid-related deaths. Depending on where you are in the country, overall I think it's closer to about just prior to 2012, or beginning in 2010, an increase in heroin deaths being associated with those. And now, of course, we have everything is being ruled by synthetic opiates. Most commonly is the illicitly manufactured fentanyl, but we're seeing all sorts of other synthetic drugs, U4770, and a lot of other novel opioid synthetics that are often not always systematically tracked through urine or toxicology screening, or even in post-mortem analysis. So this has really been perplexing the epidemic. So I do want to share a little bit about West Virginia for those of you who haven't been there. So what do we have? We have West Virginia stills and pills, right? So this is part of the life. If you haven't seen the Netflix, it's on Netflix now, The Wild and Wonderful Whites of West Virginia, I watched that well before I moved there. And it's actually, I did my postdoctoral training at the Behavioral Pharmacology Lab at Johns Hopkins. And we see in that methadone clinic intergenerational drug use there. So it's really not that, It's not an isolated rural phenomenon, right? This is happening in some of our urban centers as well. But Hard Times Tavern, you don't know Hard Times until you've come to West Virginia. You gotta ride down some of these roads and see what isolation is. When I moved to West Virginia, you know, I care about the opioid epidemic. I didn't know I cared about clean water. I'm like a clean water advocate in my part-time. Like, because I didn't realize there's people who don't have access to clean water in West Virginia. We have a lot of problems. The opioid epidemic is really just one of them. Another fantastic, this is actually a very positive story, is Heroin with an E. It really features 3 fantastic women. If you don't know, the woman who's featured here is Jan Radar. She's the first female fire chief in West Virginia, and she was recognized by Time magazine as one of the most influential people in the country. And she's fantastic. She has a great TED Talk. I really love her. You know, in a time where so many people are questioning how many times you have to overdose, how many times do I have to administer naloxone to rescue someone, you know, Jan has been on the front line saying as many times as you need to. That's my job. My job is to save you, right? So she has some really important, pivotal things in there. One of the things that's been, if you haven't seen the news about West Virginia, is almost unbelievable. There is a small town where it was just prior to when I moved there, they revealed that in a town, Kermit, West Virginia, which has less than 3,000 residents, they had received over 20 million doses of OxyContin. That's crazy. So when you think about this, who's to blame? You know, is it the pharmacy who made money? Is it the people that were selling it? I want to know how they even thought they could ship that much to a small town like Kermit. If you see these small areas, it's unbelievable. We've estimated, our economist at WVU has said it's costing the state close to $1 billion a year. So when you think about the Sackler-Purdue Pharma settlement, what's $19 billion? Is that 19 states? And that's for 1 year. How about the 20 years that we are into this epidemic? So what kind of money is that? That could be 20 million for each individual state that's been highly impacted. So it's really hard to understand these numbers. Also, I'm gonna spare you some of the real heartache in another presentation I've done. I'd be happy to share with you, is really what does this look like on the front lines? And so our morgues are overwhelmed. There are tractor trailers parked in small communities in Ohio and West Virginia because they've run out of room in the morgue. So really understanding what this is like, it's very hard to understand and wrap your brain around. This is too small for you to see, but really what this is saying is that these are all people who are dying or destitute, and the state has to pay for the transportation costs. We have one single coroner in the state, and all the bodies have to go to Charleston. And then, you know, it's like the paupers' graves, you know, we have to pay for them. We've run out of money. So it's just really the ways in which it's overwhelming. It's not just the deaths, it's every single thing that sort of wraps itself around there. When I moved to West Virginia the August before, like in many places in Ohio, this was happening. And I think this happened on the New Haven Green, but was not related to opiates, where we had 26 overdoses in 24 hours. I mean, how does a rural area respond when y'all probably only had 2 ambulances, right? I've heard community healthcare providers say, we don't have enough ventilators in our hospital. We're just not prepared, and it's really trying to changing the fabric of what's going on here. And just the poverty is really striking. And of course, I put this in here, it has to do with a little bit more politics going on in the state, but if you haven't seen, there's been recently they're investigating a HIV outbreak in Huntington, West Virginia, and the Charleston syringe exchange program has been shut down. So it's really challenging as far as what's going on. And we continue to face some significant challenges in respect to expansion of medication-assisted treatment. We have a community that rallied against one of our psychiatry residents who wanted to go home he wanted to stay in West Virginia and open a buprenorphine clinic, and the town rallied against him and had a petition to prevent him from opening in a very hard-hit community. This guy could have made how much money working anywhere in the country? And he was trying to go home and do good, and you can imagine these challenges are really quite overwhelming. This is another picture I took. You gotta love these Ohio overdose people. They're aggressive. They get like license plates on this issue. So this is a really phenomenal person, a community member that I got to work with. And so I wanna talk a little bit about some of the things we can do to prevent the non-medical use of prescription opiates. So if you're not familiar, prescription drug monitoring programs, or we know them as PDMPs, have been developed as a regulatory tool. And the data is usually generated by community-based pharmacies and also other hospitals that are dispensing prescription opiates and other controlled substances, and they have to report it into a state system. Almost every state has a PDMP now, but they vary substantially in how they're set up, who has access to them, and the regulatory policies around them. And so if you're not familiar with them, just briefly, the pharmacies, if you go to fill a prescription, the pharmacist will actually send the data to the state, and then the healthcare provider has access to this. And then this is where it varies substantially, whether law enforcement, the state health department, and who has access to that data. The main goal here, right, is to allow prescribers to be able to understand if people are potentially doctor shopping. And then some states are really using it to see if we have physicians that are overprescribing. So it's really the two parts of the equation are being addressed here. And so there's limited effectiveness on PDMPs, and part of this and this is from a national perspective, I should as the caveat. And that's because at the national level, all our states have implemented it in different ways. They have different regulations and policies and rates of uptake over the past couple of years that have really complicated this. But we're really looking to PDMPs as to sort of solve this overdose problem, which is kind of curious. Certainly in terms of identifying doctor shoppers and overprescribers, it's potentially highly effective. Whether it's reducing overdose deaths, I'm not entirely sure. Well, actually, you'll probably get a better idea by the time I'm done with the presentation. So I'm weaving throughout this national perspective some of the research that I've been directly involved with. So we actually have all of Ohio's prescription drug monitoring data and did an analysis. What they did is they passed a legislation in April 2015 that mandated doctors to check the PDMP before writing new prescriptions. This was both for opiates and for benzodiazepines. So we did a time analysis looking at pre and post the implementation of this to actually see if it was effective in reducing the quantity of prescription opiates dispensed. And so again, not surprisingly, we found that yes, in fact, it was. When we asked the prescribers to check the PDMP, we saw a really statistically significant decline in the number of prescription opiates that were being dispensed in the state of Ohio, at least. Similarly, we found this is for benzodiazepines or opiates. This is for, this is for benzodiazepines, this is for opioids, and this is for opiates or benzodiazepines. And these are multiple provider episodes, which is the more formal way of talking about doctor shopping. And so we saw a really decline in multiple provider episodes. So it seems to be getting at both parts of the equation there. One thing I should add that we looked into is that I thought was quite clever that Ohio did was it wasn't just that you had to check. They actually implemented that they checked to see if you were checking, and if you weren't, you were sent a letter that said you were going to get fined $10,000. So you can imagine uptake was taken quite seriously. And you can think about other interventions, right? Like all the legislation, public health efforts around reducing car accidents and thinking about how, we didn't always have to, click it or ticket, right? Until we started to mandate or enforce seatbelt laws, right, then we didn't actually see a significant reduction. So I thought that was a really nice way that Ohio put some real teeth behind their legislation. The second step here is to say, so we've seen this first part of the equation, which is indeed PDMPs do reduce the quantities of opiates being dispensed, but how does that affect overdose deaths? And we have this paper that we need to get done quickly. On this side, the counties in Ohio that are darker shades, they have higher overdose death rates. This side is the quantity of opiates being dispensed. And so you can see some overlap early on in the epidemic in 2007, that the rates of higher dispensing is correlating with the counties with the highest overdose death rates. You can see that really starts to expand in our middle year, but by the time we get to 2016, it's unpredictable. If you don't know the state of Ohio, what we really see happening here is what we have known is happening, is moving from the rural areas to the urban areas. And this in part is what we're trying to get at, is adding to this analysis and understanding how that's a transition from prescription opiate involve deaths to the fentanyl and the heroin, and really be able to see how that's going to correlate onto this map is a piece that we're still working on. So as a regulatory tool, I think there's no doubt that PDMPs can identify high-volume prescribers and potential people that are doctor shopping. And it really begs the question, though, then why do we need additional restrictions on opiates? So has Connecticut passed legislation limiting the number of opiates that can be prescribed on your first visit?
They limit the number of opiates that can be prescribed and for the amount of time they can be prescribed.
Do you know what the limit is? Is it 7 days or 30 days?
It's a 7-day.
7 day? Right. So I know in Ohio has some really strict legislation that they've passed probably in the last 2 or 3 years. I think in the emergency department they can only give a 3-day supply. Sounds great, right? Except if in West Virginia, I can get a follow-up appointment in 3 days. Right? I can't get to another provider in that amount of time if I have continued or a serious chronic pain situation. And the issue is that if you can check on me in the PDMP, you know, what's the real value there? I'm not being, you know, I'm being somewhat purposely provocative, but to also really think about what do we really need when we have some other tools, and are these tools being used? And understanding, particularly in areas where people, and not just rural areas, where they have access to, they have challenges in accessing good pain control, pain clinics, or even just general health care. So I really think PDMPs may be a necessary but not sufficient part of this problem. And really trying to question ourselves when we turn, and this may not be true in Connecticut, but in West Virginia and Ohio and a lot of places I've worked, we really look at the PDMP to solve this overdose crisis, right? And it's why? It's a regulatory tool, right? And especially now that we've seen, starting in 2012, that we have a lot of these deaths they're not involving prescribed medications. They may be part of the problem, but they're certainly not what's driving the majority of deaths anymore. So we've kind of like missed the bus on this a little bit, I think.
But in addition to the PDMPs, there are CDC opioid guidelines that are, have been implemented for some time. The uptake is not fabulous, but that's another tool in the armada.
Yes, I totally agree, and I'm going to come back to a related point. Jane, did you?
No, I would agree with you about that. It's focused on the prescription drugs, but think about, the sales. And we're not talking about just prescription drugs.
Yeah. So, and really trying to understand, I think in some areas where we've seen this radical change. I know I was sharing with some people this morning and earlier today, there was an article in the Washington Post. I think the study's just come out of Vermont, and I haven't had a chance to read that article because I think it was just released yesterday, where they're talking about many patients that were suddenly discontinued, pain patients that were suddenly cut off from their prescription opiates, in a particular case of a gentleman who was 77 years old. So I'm not really worried about him getting an opiate use disorder. I'm not saying that he can, right? But if we understand the trajectory, it's unlikely, and really trying to understand, and maybe he doesn't need the quantity of opiates he was being prescribed, but really understanding there's safe ways to taper, other alternative medications available, and really understanding that from swinging from overprescribing, there is no doubt that we can reduce the amount and quantity of opiates we're dispensing, and actually they mean morphine equivalent dose, of course, we absolutely need to. But what's on the other end of the spectrum? Not using these medications. So it's really sort of these challenges that we have to balance between. And that's what got me kind of interested in this. I have an intervention called Prescription Opiate Safety Education. It's a pharmacy-based intervention where we are trying to really understand how can we do sort of a brief intervention based on self-management and teaching, because a lot of our interventions are focusing on our prescribers, our legislation around this, regulations, but what are we actually targeting our patients? Because the one thing I learned in Connecticut 20 years ago, my first job working with Tom was I got the lovely pleasure of driving around the state of Connecticut and talking to people in detox. That's not a great first job, right? Like, people are not happy to see you. They're detoxing, right? And I'm asking a lot of sensitive questions, but for the foundation of my career, what did it teach me? It taught me that a lot of people want to get high, but nobody wants to have a substance use disorder. You know what I mean? I got to see it every single day. And I got to talk to people that were detoxing, right? It's fun to get high. Okay, students in the room, I don't really mean that, right? That's not literal. I'm not judging, I'm just saying, but really understanding that once it becomes compulsive, right? And it's really not fun anymore, right? You're not getting that same high once you've become accustomed to it and it's becoming addictive and overtaking your ability to make good decisions. And so really what we tried to do here is understand how can we improve the safe use, storage, and disposal of prescription opiates. And really thinking about this as overdoses and the development of addiction is a serious adverse event and how we might be able to change that. And most importantly, we have these partners in our healthcare system called pharmacists. They were on the front lines of the epidemic before anybody, right? They knew, they were calling each other up saying, oh, so-and-so's coming to get a pill again, or they're coming early and they might be headed your way, you know? So they've already been on the front lines of this epidemic, and it's really trying to understand how we can bring all our healthcare partners in to understand and do a better job at addressing these issues. So this is a picture that I did not, I swear to God, this is a real picture. I did not fake it. Portsmouth, Ohio is right on the border with Huntington, West Virginia, and this says, in case you can't see it, unique pain clinic, legitimate pain care. There were 7, they're pill mills, right? There were 7 pill mills in Portsmouth, Ohio. And if you know Portsmouth, it's just a little old town. There's nobody, they don't have that much pain there. It's just not possible. And that's what you can imagine this advertising when you come into the town. I mean, what says pills like, is no wonder they had lines around the corner to get into the pain clinic, right? They're not lining up at my primary care center, that's for sure. They're not getting anything good there. But why does it matter is you can really think about previously that we're only focusing on changing prescribers and not really focusing on patients is the other part of this. And I think about it as patient empowerment as well. And we don't even ask, when we talk about collegiate recovery, right? Because a lot of people are saying, how many prescribers right now even ask their patients if they have a history or are they in recovery before they prescribe? Any other risk factors that they might want to be aware of and really understanding that. And I think that what we're seeing more and more is that patients, at least I can talk about the ones that I've seen in West Virginia, they have seen firsthand the devastation and they do not want to become addicted. And they're really scared themselves. They've lost a family member, they've seen someone struggle, their neighbors have, they've seen their neighbors' children die. They do not want to actually become addicted. And I feel like we forget about that when we're trying to address the epidemic. We're sort of like everybody wants to get high and be addicted, and that's just not really what's going on in the reality. So we did a feasibility study when I was in Ohio in a community-based emergency department. We had really good uptake of the intervention. We actually were pretty surprised. We didn't think we could talk to people about safe prescribing. And what we were really more interested in, which I couldn't believe, is I thought we'd get all these like opiate naive people, because that's who I was really interested in, right? You're opiate naive. Before we give you an opioid, I want to make sure that I talked about education and how to use them safely and what some risk factors are and how to prevent an overdose. And in fact, 72% of our patients actually were not opiate naive, but they still had a lot of knowledge gap in these medications, which is pretty shocking. And I'll tell you, one of the things that was most telling was somebody who had came in and they had a known alcohol use disorder. They were hepatitis C positive. They had chronic pain. They were probably going to continue to be prescribed opiates, and nobody mentioned naloxone, and nobody mentioned this person's risk of an overdose. They're not the typical heroin user, but my goodness, his risk of experiencing an overdose was incredibly high given his background and information. So when I moved to West Virginia, I partnered with my colleague, community pharmacist at Marshall, and we decided to do a technology-based version of this project and to start to expand this. So we developed a website, and we actually did a randomized clinical trial. And so the key components here, and I think I have some of these with me if someone's interested afterwards, is so we developed educational materials. And have you guys seen this Dispose RX? It's quite clever. It's a little packet, and I have them with me. And you can take your prescription pill bottle, and when you're done, you actually pour it in with some water, and it will actually dissolve the medication. So it's quite handy. You can see how easy this is to actually hand that at the point of prescription for disposal issues. And we found this to be, in rural areas, it was really interesting because you think, oh, you have a disposal at your, I don't know where they are in Connecticut, but like at your police station or other different designated locations. And for our older population, that might not be a place that they're able to get to. And really understanding they have children in the house, grandchildren, and they want to keep their medication safe too. So it was really interesting and doing the education. And so you can see these are the beautiful hills of mountains of West Virginia. So just a couple of quick snapshots of what this website looks like, and it's really meant to be using a lot of visuals. And in the initial phase, we did some testing with the, this is now targeting hospitalized patients that are receiving orthopedic procedures. What's interesting here as an aside is we actually tried to pilot this in the West Virginia Emergency Department, and guess what? It was a failure because we don't really infrequently send any of our patients home with an opiate prescription. So you're not going to get an opiate in our ED at least. And so we really had to go to, well, who's still getting opiates? And of course, people in the orthopedic, that's for trauma or elective procedures, where definitely, of course, it's still warranted, even keeping in mind, of course, the CDC guidelines on prescribing. So I found this as a really great opportunity, whether the patient is directly at risk of having an overdose or not. Such a great opportunity to talk to our community members about overdose. And it's an opportunity to say, I want to talk about using these drugs safely. I'm not going to accuse you of not using them safely. I'm not accusing you of using heroin. We're not even having that conversation. I don't know. I have no idea if you have an opiate use disorder. What I'm going to communicate to you is that I care about you. And I want you to use these medications safely. And our orthopedic surgeons were actually really wanting our patients to actually take their medication because they were saying they were afraid to take them or they didn't take them. And you can imagine early in their rehabilitation therapy and being able to have that sort of functioning level early on, that was really important, that they have some pain management to help them with that rehabilitation therapy. And so it was really important. And what we found is that whether, again, the person was directly at risk or not, they have friends, family members, and other people, right? And understanding how they might be able to share this information with a neighbor, their own children, or someone they work with. You never know. So we found that patients really liked the intervention, the website rather, and that we did some small refinements around the actual education. We have some unique issues that we didn't think about, so we talk about not putting your medication flushing your medication. So again, this whole thing about, well, I didn't realize, I'm a Connecticut urban person. We had to integrate all sorts of things about people who have septic systems and different things going on, and then like the elderly that we talked about, understanding how we have to do something through the mail and some other interfaces for them. And so we have a randomized clinical trial that we did. It's quite small, and we followed up people at 30 days and at 90 days. Really what we're looking for here is this is a very brief intervention. One of the key things was, did they even retain the information that we were targeting? And of course, these are people that are not already misusing opiates and or had lifetime use of heroin, because this is not a treatment intervention for people who have a serious problem, right? This is trying to prevent the onset. It's a prevention intervention. And so you can see we're able to enroll a little over 98 people. This is really just some preliminary data. I'm going to go through this a little bit more quickly so that we have time for a better discussion. But about 77% were having an elective procedure. Most of them were unemployed. And we had fairly good randomization across our two groups, except our usual care group, I believe, they were a little bit more likely to have been prescribed an opiate and have unused prescription opiates in the house. But otherwise, we had pretty good balance using a stratified randomization procedure. And one thing we learned part of this from our initial intervention that I mentioned in the emergency department in Ohio is that when you ask people about the risk of addiction, we asked the question first, was somebody else's risk of addiction than your own? It's very interesting. Oh, it's you. You have the risk of addiction. Oh, not me. They know about the risk. It's just not themselves, right? So how do you actually engage people in behavior change when it's not, oh, that's not me. That's those other people that are at risk. So we decided to get clever this time, and we asked another question here, which is, can you reduce your risk of addiction? I thought that was very interesting. So that the jury's not out. Because I thought, oh, shoot, we're wasting our time. Because that is somebody else's problem. And I don't even know what we're doing educating people. But they're willing to say that maybe they can change their risk of addiction. Because again, and part of this having a patient-centered intervention, right, is that we want to empower them to actually make choices to reduce their own risk of having a serious adverse event, whether that be overdose or developing an opiate use disorder. Similarly, in terms of overdose risk, the same sort of profile, right? It's never them, it's those other people. And so, but again, seeing that they understand that most said that they're at least, that they can reduce their own risk. And really being able to gap that knowledge for them. So one of the things that's critical for an intervention working in this space is how do we even define non-medical use? So this turned out to be quite interesting. In the National Household Survey on Drug Use and Health, If you're not aware, this is the major survey in which all of our national prevalence data around non-medical use is based on. If you haven't seen it, this is the question. So you can imagine my pharmacy students in the hospital rooms asking this question. Have you ever, even once, used a prescription, and don't answer, pain medication in any way a doctor did not direct you to? Okay, then I'm going to go on and specify what? Including using it without a prescription of your own, using it in greater amounts, more often than or longer than you were told to take it, using it in any other way the doctor did not tell you to use it. What do you think happened? Why did they do it? Why did they say no?
It's a loaded question.
Yes. But what else is in that loaded question? It's illegal. That's exactly it. The minute we started this question, oh no. Oh no. Oh no. Well, I mean, like, everybody knows what you're asking. They're sitting in the, oh no, that wasn't me. And so we had like no one who was ever naughty, which I did not believe, right? I mean, a drug researcher, I know. I mean, I didn't have to ask you guys if you've ever done any of those things, but maybe, you know, you can understand this. So this turned out to be an abject failure. And so what we ended up doing, because I have these really clever students that I work with that are really good at talking to patients, is we actually changed the STEM question. And we said, there's a lot of different reasons or motivations for why people use prescription pain medicine. Would you ever use it to relieve pain, to get through the day, to sleep? It's a very different, it's not a loaded question anymore, right? Because it's exactly part of the issue. And so you can see what we were actually able to get. The question works much better. And we could really start to get in this. And this is really interesting, too, because this is actually still consistent with the National Household Survey. I think I added the question because you're hooked. If you actually are doing any direct clinical care, it turns out that's a word that patients do sort of resonate towards, is this idea of being hooked. It's hard to say, like, are you addicted? I don't know, I don't know what that means. Like, I don't inject. I mean, what does that mean? Like, what does addiction mean for some people? But understanding that hook, like, you feel like you have to take it. I mean, one thing I think is really interesting is we don't really address withdrawal very well. Of course, we did not have the question worded this way, but really understanding if they, you know, tried to discontinue, right? We put people on a taper for steroid medications, but we may not always address this in some of our prescription pain patients. And, you know, some of these are certainly, I'm not saying these are we're not saying these are non-medical use, right? Because some improvement of functioning is important. There's some confounding that needs more information, right? Are you taking it for sleep? You know, I mean, some patients have breakthrough pain at night, and you should maybe be taking it at night. So it's not literally for sleep. So we definitely need to do some more research on this to understand that. But what did we find out, too, that I thought was very important is when we have an open conversation and we're not pointing the finger and asking these loaded questions, is that we changed the dialogue and the conversation where we had quite a few patients, and this may be unique to West Virginia, but we had 30% who self-disclosed a family member with addiction. We had 8% that would disclose they had a family member die of a drug-related death. And we had 3 self-disclosed. And I think this was really important in the conversation. And from a learning, training health professionals, what I really loved about this is that our health professionals learn that they can ask these questions, and that people will tell them the truth. And in some cases, I think our students were really taken back because they were surprised that the patients wanted to talk to them. So we really actually had to have another intervention where we said, put the iPad down and talk to your patients. You know, and these are hard conversations. I'm telling you about the 4 people in my family who died. And I just unloaded something really heavy. But I said, you may be the first healthcare provider that they've had the opportunity to talk about these things with. So you really need to, we put everything on pause and have a conversation with that patient and show empathy and compassion.
So is this intervention limited to trying to get people to interact more safely with prescription opioids? Was there any focus at all about illegal non-prescription opioids?
Well, we, in inclusion criteria and exclusion criteria, we're hoping to, if they had admitted to non-medical use or use of heroin, they were not eligible for this particular study, so we were not addressing it in this particular intervention. We were hoping you were not drug involved. So we didn't go through a thorough evaluation as far as whether they had any illicit drug use, so certainly it's something to think about. Because
there's some evidence that when providers taper or discontinue opioids, people go on the street and buy them anyway, and that's responsible for a lot of the increase.
Yeah, well, that's what I worry about when we get to this, you know, over-prescribing to totally cutting off the supply, right? Is that how many people are turning to illicit sources of pain control?
I guess my point is that I think an intervention like this might benefit from including some content dealing with non-prescription street opioids.
We'd like to do it all.
Yeah.
I agree with you, right? We don't want to this is our starting point, but certainly that is something that we're obviously very interested in. And in part because we don't have any, there's a lot of, I think there's about 4 years from the data we've done locally. We have 4 years from the time that you've been maybe prescribed, engaged in non-medical use of prescription opiates before you maybe progress to meeting a full clinical diagnosis for an opiate use disorder. That's a big window of time. We don't have any empirical-based interventions for this for this intermediate time. What do? I know you're naughty as a clinician, but you're not going to meet full clinical criteria for an opiate use disorder. I can't get you into the buprenorphine clinic. I mean, I don't know what if you all have something better in Connecticut, but we don't have anything. What do? You say, I'm not going to give you as many prescription pills or do something, you know what I mean, or reduce your use, but we really need to think about being able to develop this. And this is one of the patients had said to one of our research assistants in the study, she said she's the only person in the family who has not had substance abuse issues. 5 years ago when she had her first surgery, she didn't take any medications because she had a fear of addiction and then was in terrible pain. So again, it's showing both sides of the equation here. So I'm not saying that there are some people who are still trying to misuse prescription opiates, but there's, you need to balance that. So our preliminary follow-up data indicates that we think that at the 30-day follow-up, that our patients are recalling the information, which shows something positive, and that they're potentially engaging in safer storage. And of course, with such a small sample size, we really couldn't get at the heart of this issue, which is if they're using them more safely. We need a much larger clinical trial to really answer that, and a much more rigorous measure of non-medical use. As you can see, we ran into that hiccup in the study. So what are some evidence-based services? I love team science. That's what that's all about. It's fun to work together. So if you're not familiar with naloxone, naloxone is like a miracle drug, right? It's like that Visa commercial. It's like it's very affordable and yet it saves lives. So it's incredibly fast-acting medication that reverses an opiate overdose. It actually is such a safe medication. It can be dosed up to 700 times the recommended dose without seeing adverse events. It's the most proximal intervention that we have to reduce and prevent overdose fatalities. And it's really just, it's been around forever if you're not familiar. I'm happy to talk about naloxone more in depth. One thing that I really wanted to bring up, because I continue to see this circulating in social media and community questions, is with fentanyl and carfentanil, you'll hear lay reports in reputable news outlets that naloxone doesn't work. That is not true at all. So I will tell you what happened during the carfentanil outbreak in Cincinnati is that you have a lot of nasal naloxone. Naloxone has poor bioavailability nasally, and so it's not fantastic if at reversing fentanyl and carfentanil nasally, but you have intramuscular, you have intravenous, and in fact, what the Cincinnati Fire Department was doing oftentimes is they'd start with nasal because it's easier, they don't have to find a vein. Then they would actually move to IM or IV, and if they needed to, and this is particularly in the case of really only the carfentanil overdoses, they could start an naloxone drip if they got to the hospital in time. So it can be used to reverse, and it doesn't mean it isn't worth the FDA or NIDA spending money to invest in to increase the bioavailability of naloxone through another mechanism, but it actually is effective. So there's a lot of, I hate to use this term, but fake news. I mean, this is just not right. So there's been cases where I've actually reached out to the reporters. This is a dated story, so I didn't. But there was a New York Times wrote an article, and it's irresponsible reporting, I thought. So some of the key things for naloxone and overdose prevention, if you're not aware, is learning to recognize an overdose as decreased respiration, and understanding that some of our patients that are in recovery may not want to disclose that they've had a relapse. And so really understanding to identify that gurgling sound is potentially, they could be having an overdose, and understanding that you might want to alert them. And in most cases, if they're not responsive to a sternum rub or their name being called, you might have reason for administering naloxone and calling EMS or 911 immediately. So we know a lot of patients are at risk because they're combining central nervous system depressants. That's alcohol and benzodiazepines most commonly. And also, obviously we already talked about the novel opiate synthetics, but we really talk about people using alone. And one thing, in case this isn't happening here in Ohio, people are quite clever when they are injecting. They have these safety protocols. It was such a problem. Actually, Walmart became a partner in Kentucky, because what were people doing? They would buy heroin in Cincinnati, go across the river, and they didn't want to die, so they would, before they injected, they would leave the car running, have the car in drive, put their foot on the brake, and inject. So if they passed out, the car would crash. This is clever, if you think about it, right? Because they wanted to be safe. Similar sort of things going on, but you can imagine it happens so many times that Walmart wanted to get involved. Because you think, oh, no, that's some random weird person in Kentucky. You know, like I've been there, you know, right? But no, it's like there's really creative things that people are doing to actually to not have an overdose and die in particular. So understanding how we might really help this population and reach out to them. But it's important to keep in mind that naloxone only reverses an overdose, prevents an overdose from turning into a fatality, whereas medications for opiate use disorder, in this case I'm speaking specifically about methadone and buprenorphine, are the only interventions as primary prevention of an overdose in the first place. And this is really overwhelming from the research. I'd be happy to share some of that with you. For evidence-based practice, what we know, it's a combination of withdrawal medications, maintenance medications to prevent relapse, and cognitive behavioral and other psychosocial therapies to address this. But we do have some barriers in understanding this, because it's really challenging 20 years into escalating overdose deaths to understand why haven't we done a better job. You know, and to a certain extent, shame on us for not doing what we need to actually stop these deaths, which are really decimating so many different communities, rural communities in particular. So we have delays in naloxone administration, particularly with these highly novel, fast-acting drugs like fentanyl and carfentanil. We have insufficient addiction treatment system capacity. Does anybody know how many, how insufficient is the Connecticut system, addiction treatment system for?
It's been expanded significantly in the past, say, 4 to 5 years, and it seems to be topping out. What there's concern about is, for instance, the waivers for physicians to administer primarily buprenorphine. And there seems to be hesitancy on the part of physicians to take on that role.
Yeah, and when I moved to West Virginia, our WVU buprenorphine clinic had an estimated 500 people on our waiting list. So when people say they don't want to get treatment, I don't believe it. 500 people on a waiting list? I mean, we're still a relatively small state. But some of the other barriers are, how do we scale this up? We have stigma as a tremendous barrier, financial barriers, and really a lack of understanding of addiction as a chronic relapsing brain disease. From the community work I've been doing over the 10 years, I can't really say. A lot of people give lip service to understanding it as a chronic disease, but then we're not really wrapping around a chronic disease model to have long-term ongoing support for these patients. So we know from national data that we have a tremendous gap. So we know that there's a limited number of our primary care docs that are willing to get waivered to prescribe buprenorphine. We know that, and there's definitely caps on the regulations for methadone programs. When they do get the waiver, they don't prescribe as many patients as they can. But Chris Jones, who's with the CDC, has done this really excellent paper demonstrating that even if every single prescriber, buprenorphine prescriber, was prescribing to capacity, we still just simply do not have the infrastructure to actually treat all the patients who need treatment. And I want to tell you how cute this is in West Virginia. So we're very proud of ourselves. We just got this paper published about MOUD expansion. We treated 196 people in the first year, which again seems small, but we're a small state. And we were able to do outreach in all these different areas of the state, which is fantastic, with this very complex model and getting people. We trained 14 agencies and 56 health professionals, but it's a drop in the bucket. 196, we need slots for 12,000 plus. What is, and I'm not putting down MOUD expansion dollars, but at 196, per year, how are we going to get up to 12,000? I don't know how if you do like ramp up. I mean, that's what I need to do is actually take a week or two off of work and figure out what is that projection model to get to 12,000, because I might be dead by then. Like, I'm older than I look, like I'm pretty sure by the time we scale up to that, I may not be alive.
Erin, going back to that,
Yeah.
projecting 12,000 plus residents need treatment. What does that mean? Who are these 12,000 people who need treatment?
It's the estimated number of people who have an opiate use disorder. And that's just we don't even know if that's accurate.
The number who we would say need treatment is never the number of people who would
Right.
show for treatment. So the treatment system can't be based on 12,000 because they'd be sitting around with a lot of clinical staff waiting. So, you know, there's.
Oh, well, I would beg to differ in part because I think this is a conservative estimate for sure. And knowing that our buprenorphine clinic alone had 500 people, you know, at any given year, I'm not sure, but I think actually the 12,000 is, people think it's an underestimate, but we don't know how many. And I agree that, you know, that not everybody wants treatment, and you certainly can, you know, what your daily intake should be is a different question.
But I think the critical issue is the uptake, because the whole point of buprenorphine is it doesn't have to be delivered in a substance abuse treatment clinic context. That was what the advancement over methadone.
Yeah.
And now here we are, everybody's getting it through a clinic. So we can't get that model to work, right?
Right. And that's one of the issues. And so you know, if you're not aware, and the Connecticut Attorney General has signed on with 35 other state attorney generals to end the X waiver. There's a really important Pew Charitable Trust hearing on this. It has bipartisan support, this legislation that's pending. I realize this is very controversial. There's clinicians that I work with in our buprenorphine clinic that are not keen on this for a lot of different reasons. But I really think about it as scaling this up. We allow physicians who, for the most part, have only had 6 hours of training on average in pain management to prescribe highly dangerous prescription opiates. And look at the regulations that we have around buprenorphine, right? You get half the high. It's half the high. It's not the full high. It's a partial antagonist, right? So you're not even going to get the full high, and we have all these overdose deaths. And in fact, it's not just that we have really powerful data from the groups in Massachusetts that access to buprenorphine is critical to reducing deaths, but we now have some data that should be forthcoming from the Dayton, Ohio area saying that even illicit buprenorphine use is associated with reduced deaths. So from a public health perspective, I need to, that's what I was trained in. Hopkins is save as many lives as possible, and I'm thinking about those 12,000 people. I'm thinking about the 900 plus that have died. Oh, in West Virginia, more people die every single year. It has not relented. And how many more people are going to die this year? 192 today alone, right? We have got to do something much more drastic and radical to increase access. People do not have to die. Naloxone saves lives, buprenorphine saves lives, and methadone saves lives. This isn't a case of, so my mother died of ovarian cancer almost 5 years ago. We can't diagnose it. We can't treat it. There was nothing that could have been done. That's not the case with opiate use disorders. We can detect it, we can prevent a death, and we really need to understand the importance in changing this. So stigma is important, and I know I'm running out of time, so I'm going to go through this a little bit quickly. Hopefully you're all aware of the problems in stigma. We did a little campaign with our health professional students. They're so clever. So one of our students designed this to look like a pill, right? So it's a prescription pill with a line through it. So we tried to get our health professional students to sign on and take the pledge to be compassionate, use person-first language, medically accurate, to stop talking about dirty urines, and really change the dialogue, right? So if we want higher uptake of treatment, really understanding how the healthcare system has to change how we interface with our patients so they feel safe and open to addressing these issues. And also, there's a lot of reasons why people don't want to get into treatment. And it goes to your point, Jane. I mean, it could be that there's 40% of people at any given time that may not want treatment. But one thing that I like to keep in mind, and this is only because I'm old now, like not 20 years ago when I worked here. What happens when you get older? You realize nobody does anything when you want them to, right? The dishes are not done when I want them to be done. I've had to let that go. Sometimes there's a little anger inside of me, brewing for like 4 or 5 days, and then I might do them myself. But, you know, I'm here. I'm not really worried about that. And maybe somebody's grocery shopping at Kroger while I'm here, hopefully. Quickly, it may not be an issue here, is compassion fatigue is something I've been really passionate about. We really think, if you think about these small communities that have been on the front lines in overdose epidemic, Ohio has spent, I think we have on record about $1 billion to address the epidemic. So you can imagine they are frustrated. And actually, some of the people on the front lines are tired. They've become callous. And if you saw it in the national news, there was a mayor who said he was only going to let people overdose twice. That was it. 2 times. And I was like, what are you going to do? Just let them die? I mean, like, that's not even an option. And why is this in the national news? It was like so horrific. But really trying to understand where compassion fatigue falls into this, and these small communities being hit hard by this. And so hopefully I have a paper under review that will hopefully be one of the first papers to describe how compassion fatigue applies to the opiate epidemic, and what we can do to help deal with burnout on the front lines. And I worry about some of the people who are working in our addiction treatment programs as well, because they may be themselves in recovery, right? So they may have experienced a non-fatal overdose, they may have friends and family, and then their patients are dying too. And to be honest with you, the students who work on my projects, our research subjects die. When you study overdose, your patients die. So really trying to understand how are we dealing with that, and some of the fatigue that's happening on the front lines. If you watch the Netflix documentary Heroin, Elaine Sheldon, who's from West Virginia, interviews one of the providers. Jan Radar talks about this, and so she says to her, the director says to one of the firemen, so how do you deal with this? And under his breath, he's like, I go home and drink. So really trying to understand what it's like to be on the front lines in these communities. And I really love this, Keith Humphreys at Stanford is just such a fantastic policy person. And so he's really saying in this quote, if opiate manufacturers face, say, a $1 million fine for every overdose involving one of their products, they would have an enduring incentive to regulate themselves. And really trying to understand the multiple layers in which we can be addressing this. So again, not just prescribers with the PDMP, with my interventions and other interventions targeting patients, lawsuits, trying to look at manufacturers, but right, what I talked to you about distributors and monitors, 200 million doses of OxyContin in Kermit, West Virginia. I mean, how the heck did that happen? So thank you so much for your attention. And I think, we have to prioritize reducing overdose deaths and linkage to services as a top priority. We need to really reinvest. We are not seeing much about early intervention with some of our adolescents and youth to reduce the risk of developing substance use. So prevention seems to we don't hear much about it at all anymore. We have to have some more novel interventions with technology to actually reach out to some of these populations. It's really hard to get new clinics and new treatment programs everywhere, and understand how we might be able to pass new legislation and enforce existing legislation. Communities don't dictate where an emergency department is, so why can we really try to get some systematic things at making some of these services available in communities, and not having to have these individual battles around the development of this. So West Virginia is wild. It is wonderful, and thanks again for your attention.
We have a minute or two for questions.
Yeah, so unfortunately, my daughter lost 2 friends about a month and a half ago to fentanyl-laced cocaine. And I've also been reading about fentanyl-laced marijuana. So these are situations where people aren't setting out to use opioids. They're using another drug that perhaps they've used for a long time, and unbeknownst to them, it's laced with fentanyl. So I just am curious about any thoughts you have about that. Why is it happening? Is it intentional? Is it accidental? Do we know what's going on here? What can be done about it? Because that seems to be a lot more prevalent than it was before.
I think many communities are actually looking at naloxone, that it's not even just doing naloxone distribution administration to not just someone who you think is your typical injection drug user or using heroin, because of exactly this issue that's happening, and really seeing anyone who's non-responsive potentially using naloxone. So that's sort of a first priority. And then educating people, it's really hard these days, right? So when I grew up in the 80s, like, this is your brain on drugs, and it was a frying pan, everybody's like, that's just some stupid stuff, right? Except you can really die now. And it's scary to do messages. Scare tactics don't work with adolescents or young people. And so really trying to understand how we do messages around that. But I think in the first place is understanding widespread use and availability of naloxone, why drug dealers are adulterating the supply of all the drugs with different novel opiates. I have no explanation for. I can say that in some cases, this is coming in through the mail. No, people don't know what it is. People try to say, oh, that's carfentanil, that's fentanyl, it's got a blue U. No, you don't know. Are you a chemist? Did you test it? We don't really know when some of these products are coming in and understanding that and what happens. And then I think part of what happened in West Virginia, it was a particularly bad batch. They probably had a higher, are these chemists that are mixing the drugs together? So it's really hard to understand. But, these are really, I want to say I'm sorry for your daughter's loss and your family, because it is unexpected and scary. This is a really challenging time, and it's hard to understand what to do at this point, to really understand the availability of naloxone and to educate people around the fact that it is being adulterated or supplanted fully in a lot of different illicit drugs right now, and that's sort of the reality, the risks that we're facing. And so also doing overdose prevention with populations you wouldn't normally think of. So being able to because part of it is sometimes recognizing those signs and symptoms, even if you think you're not at risk. So.
Erin, I had a question, or actually two sides to a question about, when you talk about pain education, we've been, the Institute of Medicine released their report in 2011 about pain education being a big problem.
Yeah.
And you said something last night just about how one of your students said, oh, besides medications, I didn't know there was anything besides, pain relievers. And there's a whole toolbox of things that we should be learning as clinicians. And wondered if you had any knowledge of other programs that have been out there, because I know there's some legislation that has been put into some states where they have to do some pain education, which is all pharmacological, as part of relicensure. But I don't know of any other really good programs that provide the whole range of different non-pharmacological type of interventions we should be using for pain, as well as that whole piece about, they learn about pain management, but what about addiction medicine? And I don't think we're addressing either of those issues.
I completely agree, and understanding that's one of the things that I think we were talking about is that, again, 18 years into this, and what have we done in our health professional education system? I am really dedicated to this at WVU, right? We have the highest overdose death rate. I want every single one of our health professionals, I'll probably die before it happens, but to be trained in understanding some of these issues to be able to do a better job. So I think there are some resources I'd be happy to get you with. CDC, they're minimal, but not maybe sufficient. But for our TPO's website, we actually had links and information on it because we spoke to that issue directly to our patients. They actually have some really nice infographics for patients about non-pharmacological management of pain, which I think is really important. And I believe NIDA has some resources as well. Are they sufficient, and how are they actually being integrated into standard medical education is not efficient. And I do know that some states have variable ways in which they've changed their CME regulations or CEU regulations, where you can really sort of, your physicians or your other healthcare professionals that have already been trained, to actually address that through annual credits. And they have different mechanisms that the states have been able to do that to their healthcare professionals. So it's probably not a sufficient answer, but at least I can definitely send you some more resources. So, oh my God.
So I like that you ended up on this prevention, and I'm not sure what that looks like specific to preventing the opioid or impacting the opioid crisis, because it links up to the statement of, if we had to organize the entire sort of healthcare provider system to respond to who's at risk for this, it's like an impossible endeavor. The other point I want to make is that getting sufficient people in the workforce to address the addiction need is also a huge and impossible endeavor.
It's not impossible.
Well, it's like
we can do it.
Stay in addiction treatment.
Yeah.
it's the, when we have programs for training and incentivizing folks, even in social work, it's very difficult
Yeah.
to draw people into that. People don't, that, the stigma.
They don't know how
They
great
don't
these
wanna work
patients are.
in addiction. So that's just a whole
Yeah.
nother issue, is getting,
Yeah.
mobilizing a workforce it's an uphill battle, and unless we start talking about prevention, we're just gonna keep getting behind the curve.
For the education, I can say, like, seeing students light up when they realize these patients aren't as scary as they want. And I have a primary care doc that I've had the opportunity to work with in North Dakota, and she didn't do addiction, and she kind of like slowly scaled her time up. And when she talks, I love to have her on panels because she really talks about, she used to just help people manage diabetes. Now she helps people get their kids back. Now she helps people stay alive. Now she helps people, you know what I mean? So seeing actually some of these individual physicians and other healthcare providers really see a transformation on the impact that they're having in lives. And there's a particular story that was in the New England Journal where a doctor was hesitant. She actually was very brave in sharing her story, where she had a standard patient for 20 years who ended up developing an opiate use disorder, and she refused treatment and the patient died. And it's a very honest telling of her regret to help that patient. But I think we can do a better job, I think, in the healthcare professional. And I think, at least in my perspective, is helping them see how rewarding it is to work with these patients, but giving them the skills that they need to feel more confident in those interactions. Because I think it is really hard to talk to these populations when you don't have the skills. You don't know how to talk to people. You didn't know that you could talk to people about these risky behaviors. You don't know that they'll tell you the truth. And then what to do when they unload the 5 people, like I said, the one story where when they unload these very challenging stories, and how to actually be able to respond with that, and then not take up your whole day, right? So it's a skill, right? So it's not a perfect answer, but.
Unfortunately, I think we could go on forever, but we have to here. Thanking Dr.